All right, thank you very much and welcome. I'm going to be discussing the health equity impact assessment that I completed as part of my practicum. First, I wanted to take a moment to acknowledge the lands of the Strait and Coast Salish people whose land we are on today, but also the lands of the Anishinaabe people whose land I did my practicum on and that I've been a visitor for 23 years. So you can see this little island here is where I've spent my time doing my practicum and living now currently. So today I'm going to discuss the special needs program at the Manitoulin Central Family Health Team, but most of my time I'm actually going to discuss the health equity impact assessment, the strengths and limitations, and its application to the wider public health field. The Special Needs Program at the Manitoulin Central Family Health Team, or MCFHT, addresses two special needs populations, the population living within the community and the community living population. Community living, for those not familiar with that model, is an organization that provides daily support with living for those living with a developmental disability. For the wider population, the foci of this program was prevention and education. And while this continues to be a focus for the CLM population, the case management and annual physicals are also added. So this is the special needs program flowchart that I created that represents the flow of a patient through the program. This program looks to address the needs of a specific population with complex medical needs in a proactive way rather than a reactive way. This program has been in operation for approximately 2 years, and it was my task to assess the program's success from a health equity standpoint. So the health equity tool was developed by the Ministry of Health and Long-Term Care, and it's not only intended for use within the healthcare system, but all organizations that may have an effect on health outcomes. So this step-by-step process is intended to be completed by the programming, planning, or policy development team to both identify unintended impacts and discuss potential solutions. This tool is very dependent on good evidence, as the evaluator's report will lead to policy and programming decisions, and without good evidence, poor decisions could be made. So the HEIA was developed by the Ministry of Health and Long-Term Care in 2011. And on a practical note, its job is to identify unintended potential health impacts of decision-making, both positive and negative, on specific population groups. The next 3 goals look at how to embed equity as a focus for the organization. They are support equity-based improvements in policy, planning, and program service design, embed equity in the organization's decision-making processes, and build capacity and raise awareness about health equity throughout the organization. So the tool has 5 sections: scoping, potential impacts, mitigation, monitoring, and dissemination. To get a better idea of how to use this tool, I'm going to run through a brief example. So the scoping process identifies the populations that are affected by the program. And this specific example was taken from the special needs HEIA that I completed and looks at the low-income population. The potential impacts phase looks at the unintended impacts, both positive and negative, that may occur. The final 3 phases that are represented here, mitigation, monitoring, and dissemination, each look at different ways. So the first phase here is looking at how you would reduce a negative impact or amplify a positive impact. The second section looks at how you would measure whether or not that mitigation strategy is working. And the third section is looking at how you would actually disseminate that information to the public. So one discussion that was central to the special needs HEIA was about conflicting models of care or models of care that aim to work together to provide care for special needs individuals. So while that's a much larger discussion, I think what it shows is how you can have a large policy conversation from a very specific tool. So while models of care were specific to the special needs HEIA, the access and accessibility both continually arose as I applied this to different programs. So access was highlighted specifically in terms of the rural setting in which I was completing the HEIAs, and this geographical access to care was a major issue. In a rural area such as Manitoulin Island, many of the access concerns are not limited to the developmental disability population, but in fact are concerns of all individuals. While I highlight physical access, many other access issues can be highlighted by the application of the HEIA. As well, the HEIA highlighted the need for increased accessibility for all. Many programs are designed in response to specific concern, and a quick implementation in the healthcare field has increased accessibility issues for many populations. Language, culture, and stigmatism can all play a detrimental role in the accessibility of certain health programs. The HEIA looks to proactively address these issues. So the strengths of this tool include that what it does is it evaluates unintended impacts. So this unique perspective allows for a robust evaluation, and the evaluator is forced to kind of step outside their own experience and walk a mile in the shoes of other populations. This tool recognizes intersecting populations, so one example being a rural Aboriginal population. This tool is demographic specific, which is very helpful for both organization and focus. Due to the fact that each population is separated by a demograph, it gives the direct attention, value, and focus to each of these populations, including those intersecting populations. Finally, it allows for future action to be documented. When more people know about what needs to be done, it is more likely that such action will occur. So some limitations were noted, and I will say that most of these limitations were in terms of my specific HEIA rather than the tool itself that was developed by the ministry. So broad statements were made in some cases, and it was challenging to adapt that scope to make a concrete statement that would hold true for the entire population. Data standardization was limited in some areas, and so I was unable to access specific statistics. Specifically to my review, the timing was not done according to the suggestion from the ministry. The ministry workbook suggests that it's actually done prior to the implementation of the program, whereas when I completed it, it had already been in operation. So finally, the valuation is limited based on my experience, as the workbook recommends someone who is involved in the program to complete the review. And whereas I had some knowledge of how the program was operating, I was not involved in the direct service provision. So while I was operating in a primary care setting, as I mentioned, this tool was designed to address health equity in the broader context of both the social determinants of health and health outcomes. This tool is very adaptable, and its adaptability stems from the fact that the populations being examined are determined by the evaluator. As well, the tool demands change, as it ensures change is addressed, and the sharing of the proposed changes with the community allows for shared responsibility and accountability. So the HEIA tool, through its application at the MCFHT, has provided valuable lessons to me and solidifies itself as a tool that will continue to gain popularity among public health assessors. My application of the HEIA at the MCFHT has highlighted the benefits and limitations of this tool. And while this tool is not without its limitations, it does address health inequities and guides the users to concrete solutions to address such issues. Health has become a broad topic affecting all policies and programs, and it is imperative that such tools, such as the HEIA, are applied regularly. Such assessments will assure that the programs, policies, and initiatives decrease the health inequities faced by people in our society today. Thank you very much.
awesome.
Thank you.
Questions for Nick?
Okay. Well done, Nick. Thank you very much.
Thank you.
You mentioned that one of the strengths you saw of the HEIA was the fact that it identifies particular populations, so there's certain demographic considerations that should be considered. Can you think of any negative implications for organizing an equity-focused tool in that way? Do you see what I'm asking?
Mm-hmm.
Yeah.
So I think where I struggled with that was the fact that it's boxed. So it becomes boxed. As you saw with the example, it's a specific population that you're addressing. And so when you look at the complexities of any individual's life circumstances, they may fit into 5 or 6 of the different population groups that you're trying to specifically address. So when it comes time, and this is what I've been doing most recently, is gathering all of the recommendations made by this tool, it becomes hard to separate it to address a specific situation. So I think the downside of organizing such a tool in this way would be that you are limiting a person's circumstances into a specific population.
Indeed. Anyone else? Quickie? Oh, I mean a quick question. Lynn?
Yeah. Thanks for clarifying, Charlotte. I was worried. So this is a question out of left field, but as people who've worked with me know, I like to do this. So is the notion of equity in this tool based more in Western conceptions or Indigenous conceptions?
I would say it's a Western-based model of equity. Certainly the 43-page workbook is very government language, very westernized language in the way it wants you to follow a step-by-step guide. Less mention of some collaboration and things that you may see in another model, but it certainly would work in a government setting where you're looking to check off certain process pieces of your evaluation.
Should we move along? Miss, Doctor, Mrs.? I don't know what your name is. Thanks, Nick.
Thank you.